In vitro fertilization. In vitro fertilization, or IVF, is a procedure whereby an egg is fertilized by a sperm outside the woman's body. It is considered an assisted reproductive technique. The oocyte, or egg, and sperm are collected from the woman and the men respectively and fertilized outside of the body in a laboratory. The fertilized oocyte, also called an embryo, is then replaced into the uterus or womb. There are many reasons someone might want to perform in vitro fertilization. These include moderate to severe male factor infertility, tubal blockage, failure to conceive with alternative assisted reproductive techniques, advanced maternal age or low ovarian reserve, and other miscellaneous reasons such as endometriosis or sexual dysfunction. Here are the different stages of in vitro fertilization. The first stage is pituitary downregulation. This stage is meant to reset the woman's brain from sending signals to the ovaries to initiate ovarian follicular development. This prevents premature surges of luteinizing hormone to avoid unplanned ovulation and allows the fertility specialist to stimulate her ovaries so that a maximum number of oocytes can be obtained using injectable medications. There are two main types of ovarian stimulation protocols: the gonadotropin-releasing hormone agonist protocol and gonadotropin-releasing hormone antagonist protocols. The gonadotropin-releasing hormone agonist protocol requires 2 weeks of injections to downregulate the anterior pituitary gland prior to ovarian stimulation. Hence, it is called the long protocol. In the gonadotropin-releasing hormone antagonist protocol, or the short protocol, this medication is given concurrently during ovarian stimulation without the prior 2 weeks of injections to downregulate the anterior pituitary gland. Both methods have similar success rates, and fertility specialists will assess a patient's condition to decide on the protocol to use. The antagonist protocol is more commonly issued as it requires less time. The second stage is controlled ovarian stimulation. The goal of this step is to stimulate the woman's ovaries to produce multiple follicles. These follicles contain the developing oocytes. Gonadotropin injections are given over an average of 12 to 14 days for the follicles stimulation. These include follicle-stimulating hormones with or without luteinizing hormone as well. Once at least 4 follicles reach at least 17 millimeters, a trigger injection is given to stimulate maturation of the oocyte to prepare for retrieval. This brings us to the third stage, oocyte retrieval. This occurs approximately 36 hours after the trigger injection. It is a minor operation performed under sedation or general anesthesia. The ovarian follicles are aspirated vaginally under ultrasound guidance, and the follicular fluid collected will be assessed by the embryologists who will pick up the oocytes. The next stage is sperm recovery. Similar to collection of semen for analysis, the man will be present in the hospital on the same day as his partner's oocyte retrieval. A semen sample will then be collected. In cases of severe male factor or men with azoospermia, sperm may have to be collected by a urologist in a separate minor surgical procedure and frozen for subsequent use on the day of oocyte retrieval. Next is the fifth stage, fertilization. Fertilization of the oocyte and the sperm occurs in a laboratory performed by embryologists. Only mature oocytes, as assessed by the embryologists, can be used for fertilization. Upon successful fertilization, the embryos are then allowed to grow in culture media and will be assessed daily by the embryologists for further development. They may be grown to day 3 embryos, known as the cleavage stage, or day 5 embryos, known as blastocysts. The sixth stage of in vitro fertilization is embryo replacement. This can be performed fresh or frozen. It is a minor procedure which requires no sedation. A speculum examination is performed and a thin catheter is inserted into the uterus through the cervix under abdominal ultrasound guidance. In the case of fresh transfers, they are performed a few days after the oocyte retrieval. A day 3 or day 5 embryo is replaced into the uterus. For frozen transfers, the embryo is frozen after fertilization and kept in the laboratory. The woman awaits the arrival of her next menses before planning to replace the embryo. To ensure that the uterine lining is ready for implantation after her next menses, she may use her natural menstrual cycle or hormonal medications prior to the transfer. The 7th and final stage is the luteal phase. A combination of hormone medications, including estrogen, progestogens, or both, may be given after embryo transfer. This is to provide luteal phase support, and they may be administered orally via injections or vaginal pessaries. Finally, a pregnancy test will be performed 14 to 16 days after the embryo replacement. In vitro fertilization is a safe procedure, but there may be complications which can be hormone-related, procedure-related, or pregnancy-related. Hormone-related risks include ovarian hyperstimulation syndrome, which can occur in severe form in 3 to 8% of women undergoing assisted reproductive techniques. This causes fluid in the body to move out of the blood vessels, so patients may feel nauseated, bloated, breathless, and swollen. Additionally, their weight will increase rapidly daily. This may occur when patients have very good ovarian reserves and respond excessively to ovarian stimulation. Injection of the human chorionic gonadotropin trigger prior to oocyte retrieval can result in ovarian hyperstimulation syndrome in these women, which can be further exacerbated if the woman gets pregnant. During pregnancy, more human chorionic gonadotropin is produced to maintain the pregnancy, which can worsen the symptoms of the syndrome. In women who are breathless, in pain and very uncomfortable, they will need to be admitted to receive treatment. Ovarian hyperstimulation syndrome is diagnosed through blood tests and imaging studies as required, such as pelvic ultrasound and chest X-ray. Procedure-related risks mostly pertain to oocyte retrieval, where minor bleeding may occur in 14 to 18% of patients. In addition, there are small risks of infection, major bleeding, and injury to surrounding structures, such as the bowels, bladder, or blood vessels. These have an occurrence rate of less than 1%. Finally, in vitro fertilization carries pregnancy-related risks in both early and late pregnancy, as well as to the offspring. In early pregnancy, patients have an increased risk of miscarriages, and congenital anomalies may develop in 6 to 7% of cases. Ectopic pregnancies are pregnancies located outside of the womb and occur in roughly 8% of cases as well. Heterotopic pregnancies, where one pregnancy is located in the womb and the other is outside, is rare and occurs in 1 in 8,000 in vitro fertilization pregnancies where more than one embryo is transferred. In late pregnancy, there is an increased risk of preterm delivery, especially in twin pregnancies. Other complications include increased risk of small babies and generic risks such as intrauterine fetal demise, hypertensive disorders, and gestational diabetes. Finally, there are some risks pertaining to the offspring as well. There is an increased risk of admission to the neonatal intensive care unit in the case of preterm deliveries and perinatal mortality. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.